A patient will come to you with an abdomen pain, severe abdomen pain, mainly in the epigastric region or the left lumbar or iliac region at first. So why in that area? So there's a Murphy's diet you might be knowing. So in that first is the abdomen pain, then you will be having vomiting, then fever. Hey guys, myself Dr. Roman Natwani, surgery resident at present. So yeah, today we'll be discussing on a topic that's an emergency, that's acute appendicitis. So from the name only you know that it's an acute condition, and appendicitis means that it's an inflammation. Itis is inflammation, as you know, the inflammation of the appendix. So where is the appendix? It's in the right iliac region, as you all might be knowing. So yeah, it's around size you can say 7.5 to 10 centimeter in size. It's present in the ileocecal region, ileocecal valve, or if I can say 2 centimeter below that. So coming back again, not deviating and coming back to the topic. So yeah, how will the patient present to you with? The patient will come to you with an abdomen pain, severe abdomen pain, mainly in the epigastric region or the left lumbar or iliac region at first. So why in that area? Because as you all know, appendix is in the right iliac region. But yeah, the patient will present at first with the epigastric pain, and you can confuse with other like gastritis and all. But yeah, so why that? As we called as the visceral pain. Visceral pain is basically with the same dermatome. You will feel the pain on the left side or on the epigastric region. So yeah, you will feel because of the visceral pain that is the direction of the appendix. So then slowly the pain will be localized to the right area, that is the right iliac region, as the somatic pain. Somatic pain basically because of the irritation of the peritoneum, because of the inflammation of the appendix. So how would the patient present? So there is a Murphy's diet you might be knowing. So in that first is the abdomen pain, then you will be having vomiting, then fever. It's not a necessary, but yeah, there's a triad like that. So basically you will come with the vomiting, abdomen pain, fever, and constipation or diarrhea. Constipation is the most common, but yeah, constipation or diarrhea you can come. So yeah, next what will you do? When a patient comes to you like this, you will have clinical findings. The clinical findings you will do, and then you will send an urgently for USG. What are the clinical findings? There are many signs in that. So the first line, as you all might be knowing, that's a McBurney's point. McBurney's point is basically lateral one third and medial two third. From I'll just repeat again. From C, you will make an imaginary line from the umbilicus and to the anterior superior iliac spine. In that imaginary line, the medial two third and the lateral one third from the right iliac spine, there will be a point and there will be tenderness. That's basically where the appendix lies. So we will feel the tenderness at that area. So that's one finding. Then you have some findings which you can elicit or you cannot elicit, but yeah, you have to remember that findings. Then we have the Robson sign. Robson sign is basically when you palpate on the left area, right, left iliac region, you will feel the pain on the right iliac region. Why? Because yeah, as I said, same dermatome, there will be same dermatome, and secondly, basically the bowel will be moved with that area. When you press, a bowel will move to that inflamed area. So yeah, secondly that's the Robinson sign. Then what you have is other signs like the Sohas sign. Sohas sign or the then obturator sign you have. But really Sohas and obturator sign you will see in the different conditions. See, Sohas sign you will see in the retrocecal, basically that's the most common. So yeah, again I will go back to that. What are the commonest positions of appendix? Commonest will be retrocecal. Then we have the pelvic. Then we have the paracecal, then posterior, preilial, and all that are there. Posterior, preilial, retrocecal, and all that are there. Today we have 6 positions like that. So yeah, so that pararetrocecal is the most common. In case of retrocecal, what you will find, you will feel the psoas sign. You will feel. So what you will do when a patient is lying down position, he lifts his right leg. Okay. When he lifts his right leg, there will be a pain. That's the psoas sign. That's the positive psoas and retrocecal. If it's a the pelvic position is there, you will find the obturator sign. You have to lift the right leg and move internally. So when you move internally, it will cause a pain in the right iliac region. That's the obturator sign. There are many more signs in because with respect to the positions and all that. Like the Baldwin sign we have and all that. When you lift the leg, there will be a pain. So we have different signs, but most importantly, what we see clinically is McBurney's point and Sova's sign, Robinson sign. We can find elicit basically like that, another science we have. So now other thing is, what will you do? So when a patient comes to you with you elicit clinical findings, you can have a thought in mind, and there can be many things in that. There are many differential diagnosis for that also. So what is the most common differential diagnosis? It depends on the age. So what I have seen is most commonly we find is the mesenteric lymphadenitis, because it mimics acute appendicitis in that case. You can have Meckel's diverticulum also, but it depends on the age. What is the age group? In adult, you can't find a patient with Meckel's diverticulum normally, generally. So yeah, there are many differential diagnoses like duodenal ulcer, which will cause pain in that area, radiates into the area, and cholecystitis, carcinoma, carcinoma cecum, Crohn's, TB. So there are many reasons for that which will cause you this. So yeah, I don't think in that way that these are the findings. So next we move on. We don't the findings. We send the patient for urgently USG, because documentation is very important in this. We cannot just go with the findings. So yeah, coming back. Then findings are over, investigation is over. What other investigation you can provide? I think anything you think about it. If we are in any confusion that to an elderly patient or it is not, we cannot visualize in the USD, we can go for CECT, of course. In case of pregnancy, also many times we can find it's not that rare, but yeah, you can find appendicitis. But in that case, you have to go for MRI, because the appendix will be lifted upward. So MRI will be a very good investigation of choice in that case. So CCT, MRI, rare, or USD is the most common what we do. In X-ray, you can different for differential diagnosis. You can for like of you're thinking of obstruction, retinal colic, or something like that. It will differentiate basically, but not for acute appendicitis. Appendicitis won't be seen in the X-ray, but you can differentiate other differential diagnosis in that condition. So next, moving on. In findings over, investigations over. Treatment. What will you do? Say treatment basically depends on the age group. For example, when you have a child or an infant, you have to do it. You have to do it. Emergency appendectomy. Okay. If in an elderly, in that case also. In case of children, what happens is the pain on the appendage inflammation will not be localized. Localized in the sense appendicular mass won't be formed. I will discuss what is appendicular mass and all that. But yeah, it won't. It there are high chances of perforation. In short, there are high chances of perforation in case of children and infants. In case of elderly, there are high chances of perforation as well as gangrene can be present because of the supply, decreased supply, and gangrene can be present. So in elderly and in children or infant, you cannot take a risk. You have to go for laparoscopy, as it's very common these days. Laparoscopy or the open appendectomy you have to do under GA we do, or SA, whatever you wish. But yeah, let's coming back where I was is treatment part in children and adults. You have in elderly you have to do. In case of adults, you can wait. If you wish, suppose a patient comes to you with on 3rd or 3rd or 4th day with severe pain, and you actually show the appendicitis, but they came with to 3rd, 4th day, then you cannot go for operation. Why? Because at 3 to 5 days an appendicular mass is formed. Now, what's an appendicular mass? Actually, what happens when an appendicitis occurs? All the areas around it, all the areas around it means like peritoneum will be there. Then we have the ileum, we have the cecum, then we have the mesentery. All that will come to that place, just to localize, just to cover up that appendix, so that the infection doesn't spread to the other parts of the stomach or the abdomen area doesn't spread. So you will feel a soft, non-mobile, tender mass under that in that area only. That is the right iliac region only, below the sub ileocecal orifice. In that area, you will be finding a soft, non-mobile, tender will be present. Non-mobile with respiration also. Non-mobile doesn't move with respiration also. So you will find out that finding. So in that case, when you feel the clinical finding on the 3rd or 5th day, you don't go for simply go for operation. You have to wait. So what will you do? Yeah, there is something called as the Osner-Seren regimen. So in that, if the patient comes to you with an appendicular mass, it is on a 5th day. So in that case, you won't operate. You have to treat it conservative. What's the conservative management? Conservative management is very simple. Check for vitals, BP, pulse rate, temperature. Then you have to give for nasal acid tube. You have to give IV fluids, analgesic. You have to give for the pain and antibiotics. Antibiotic like anything which will cover broad spectrum, like we have to give omegacin, gentamicin, or ceftriaxone, whatever you wish to give. That's a broad spectrum antibiotic we will give, and wait. So till when to wait? See, normally the patient will recover from 48 to 72 hours. Within 48 to 72 hours, the patient will recover. But if there is any complication, like after fever, it is a high fever, not controllable fever, hypotension, shock, if the patient goes for shock, that is, I would think that is a perforation. So in case of perforation, you can't take a risk. In any way, you can't take a risk in case of perforation. So I would think in that way. So yeah, what I said is the steroid regimen and analgesic vitals and antibiotics, nitric acid tubing, and just wait for 72 hours. If it doesn't happen, yeah, you have to go for the operation. But yeah, within 72 hours, if it reduces, so you have to uh, take an internal appendectomy. That is, after 6 weeks, you will call the patient and then do appendectomy, because there will be a high chance of recurrence. So yeah, high chance of recurrence in that case. So that's an Arsenal setting regimen. Then I said everything, but the main thing I didn't tell is what's the etiology. So etiology is basically, in this case of an appendicitis, is it's will be divided by the types. Like what are types in that? See, we have the obstructive, non-obstructive appendicitis. Then we have the recurrent appendicitis. We have the subacute. Subacute basically the lighter form, not that much symptoms will come with subacute. And we have the stump appendicitis. So yeah, so so basically, worse than non-obstructive, non-obstructive basically there is a mucosal edema, because of inflammation due to anything like a viral infection or a worm. But basically, the thing which will not cause the obstruction of the appendix, that's a non-obstructive appendicitis. Then we have the obstructive appendicitis. The obstructive appendicitis is basically something has gone inside, or the lumen is obstructed. How will the lumen obstruct? The most common cause, I will just tell you, the most common cause for appendicitis is fecalith, that is a fecal material in that area, which will cause obstruction. Then the lumen gets edematous, inflammation signs, and all that. You will see it's dilated basically. And the blood supply, that is from the appendicular artery, which is a branch of ileocholic artery. And the appendicular artery is in the mesentery, that is the mesentery which attaches to the mesoappendix, we call it. So that also blood supply stops in that case, and if it's more tight, blood supply will stop and cause gangrene, and there are high chance of perforation in that case also. So we have, I just told you the non-obstructive, then obstructive from the renal, that is the worms, whatever tapeworm and all that, also we can cause obstruction to that area. We have other things also, but there are many causes like that. See, viral, that worms, then fecolith, then anything like strictures, like Crohn's disease can come, TB and all that will, carcinoma will obstruct the area. Something which obstructs at the obstructive appendicitis. Then I told you recurrently it coming, it resolves recurrently. Then I told you it's subacute, I already said. There's stump. Stump is basically, you did a laparoscopic appendicitis in this case, and then laparoscopic appendicitis, you left a stump. That is, you didn't cut the full appendix, you left a stump, or the stump area is there. That will call again appendicitis, or inflammation. So it will lead to appendicitis. Again, that's the stump appendicitis. So where I was, I am just going here and there, but yeah, we did that etiology, we did at last. But yeah, etiology, clinical features, investigations, and the treatment. Treatment is, also, as I told you, that is in children, it's we have to do children and elderly. We have to do an operation urgently. In elderly, we can wait. We can wait. We can wait for the Osner saline regimen, and we will do it all that. So after Osner regimen, it's over. Then coming back, what are the modalities? Open appendectomy, and then we have a laparoscopy is very common. Open, it's also not that much big incision, but yeah, laparoscopy is preferred these days. So laparoscopic appendectomy has to be done. So coming back, there is something called appendicular mass. As I told, there is something other also other thing which is called as appendicular abscess. Absolutely, the suppuration is there. You have suppuration is present. That is a pus. Pus is filled in that appendix area. That is the suppuration of the appendix. So what we will do in that case? Monitor the vitals. If the vitals are okay, we can give general anesthesia. In that case, we will just open. We will just open, and then we will just remove the skin, but of small incision in the skin, and then external up to external oblique muscle will just remove and see the area where the area abscess is there. And we'll just break it and just remove the pus in that. So in short agency then is only, but yeah, you have to do it in GA. And then all aseptic precautions, you have to do it in GA. Or you can just put a catheter. Just we can put a catheter inside for the drainage of the pus. And after 3 months, remember this. In case of appendicular mass, it's 6 weeks. In case of appendicular abscess, it's 3 months. You have to wait for 3 months, and then you will have to do a appendectomy, whatever you want in the laparoscopy or open appendectomy. But yeah, you have to remove on the inside and the inside and then on the GA. So yeah, thank you so much for listening to me.